you know.
So just letting you know too, I saw the email from Michelle Johnson. And so I'm going to bring it up tomorrow at the meeting, her availability compared to everyone else's availability. So I know that you won't be able to be at the meeting, and I know that Jen won't be able to be at the meeting. So I'll email Jen this afternoon, but if you could look at it and just shoot me an email as to what your availability to Michelle's is.
Sure. Yep.
And then that way we can try and get that scheduled.
Sounds good. Okay. Thank you. And I'll just be here until a few minutes before 1. I have to hop out for a student meeting. So Devin's going to help you run the slides.
And just the same thing as last time, right? I'm just reading the question to them. Devin will open up their answering poll, then we'll pull it up and I'll discuss why one was right as opposed to the other.
Exactly. Same thing. Yep. All right. Thank you.
Not a problem.
Actually, why don't I go ahead and they all know you, but I'll just quickly introduce you. Thanks, Devin, for sharing the slides. All right, guys, we're going to go ahead and get started again. I know you all know Miss Trinka because you had her for OB, and we're really fortunate that she is willing and able to come back and do the maternity portion for you all, because this is just not an area that Linda and I are experts in like Miss Trinka is. And so I want to thank her for her time and her expertise, and she does a fantastic job doing this presentation. So without further ado, I will just go ahead and turn it over to Miss Trinka. But really quickly before that, if you guys are noticing, or let me see, how many? 53. So we might be missing a few. So if you guys can just text your classmates and let them know that we're in the second link. I'm going to put the passcode here in the chat. They shouldn't need it, but in case they do, oops, I just sent it to Devin by mistake. I'll just put it there in case they're having trouble getting in. Devin, are you ready to go? Or he might have stepped away. I'm not sure. It looks like you pulled up the slide. So Devin, I think you're good, right?
Okay, so I'm still getting, I'm on a different computer today, so I'm still trying to figure out like what screen goes to what, but I think we're good.
Yeah. Okay, yeah, it looks good on our side. We can see the slide.
Okay, wonderful.
All right, thank you.
All right, are you ready for me to take over, Angie?
Whenever you're ready, Missy, it's all you. Thank you so much.
All right, everyone. Hello, and it's good to be here. Let's go on and get started with this first slide. So this is a slide that most of you are probably pretty familiar with. We went over this when we were just starting out your OB class. So when we're looking at gestational age and fertilizational age, these are two different things that are being noted. So when we talk about the gestation, 9 weeks gestation, that gestational age is actually measuring the age of the baby from the woman's first day of her last menstrual period. Now, if you remember back, there can actually be about a 2-week difference between the last day of their period and when conception actually happens. So that's what our fertilization age is from the time of conception through the pregnancy. Now, when we hear how many weeks a patient is pregnant, that will always refer to the gestational age of that pregnancy. The doctor cannot truly determine unless there has been an intervention to pregnancy, but natural pregnancy occurring can only be determined by that woman's last menstrual period. We don't know exactly which day in her fertilization process she actually conceived. So when we refer to our age of the pregnancy, it will always be in gestational age that we're looking at. But just know that the difference between that gestational age and the fertilizational age is that the fertilization age goes from the day of conception. So that's why there's usually about a 2-week lag between those two dates. Next slide, please, Devin. Okay, so when we're talking about uterine enlargement, Hagar sign, ballottement, these are all things that occur throughout the pregnancy. So the uterine enlargement starts to begin immediately. As soon as the woman becomes pregnant and that cellular process begins in the uterine lining, and the formation of that placenta is taking place, that's when that uterus has to start getting larger to accommodate that pregnancy. Now, if you remember, we talked about being able to measure the pregnancy uterus. So if a patient is, say, 12 weeks pregnant, we should be able to take a regular tape measure, put it on the mother's pubic bone, measure up to where we feel the top of that fundus, so the top of the uterus, and that measurement should be the same as how many weeks the patient is. So 12 weeks pregnant, we should have a measurement of about 12 centimeters. Remember that we do allow either 2 centimeters above or 2 centimeters below when we're looking at the size of the uterus. So if we have a patient that is 12 weeks and she's measuring 13 weeks, we don't really worry about that. We just continue to monitor it. If the patient would continue to measure large or go above that 2 centimeters that we like to see, then we will wind up then investigating as to why. But that's a whole other section and a whole other series of problems. When we're looking at Hagar sign is a softening of the uterus. It can only be noted with a vaginal exam. In the beginning stages of the pregnancy, usually around weeks 5 to 6 of the pregnancy, if the doctor does a vaginal exam and pushes down on the uterus from the abdominal side against the bottom of the uterus where his fingers are for the vaginal exam, he can tell that the uterus is very soft. And that softening happens because of the changes that are taking place in the uterus to allow the uterus to start to grow for that baby to be able to grow in the uterus, for the fetus to enlarge. The uterine wall has to be soft in order to be able to continue to expand. And so that's what Hagar sign is that softening of the uterus that can be palpated through a manual exam. And again, it usually can be seen at about week 5 or 6. And then ballottement, sometimes as the pregnancy is advancing, if a doctor pushes on or taps against the cervix in a vaginal exam, the baby will bounce away from that noise or that pressure on the cervix. And that's ballottement. They're able to bounce up in that amniotic fluid, rise up and away from that cervix. And they stay up and then they'll come right back down to the position that they might have been in. Again, it's only noted when some type of force or tapping or noise is happening to the cervix, and it just causes that baby to bounce up and float away and rebound from that sensation that they're feeling. Next slide, please. So this is going to be one of your first questions. The nurse is collecting data from a client seen in the healthcare clinic for a first prenatal visit. The nurse asks the client when the first day of the last menstrual period was, and the client reports February 9th of 2015. Using Nagel's rule, the nurse determines that which is the estimated date of delivery. You can go on and close the poll. All right. So it looks like quite a few of you got this correct. November 16th, 2015. So number 3 was the correct answer. Remember Nagel's rule, guys. We went over this quite a bit in class. Nagel's rule, you find the woman's first day of the last menstrual period, and you're going to subtract 3 months from that. So in this one, it was February 9th. So if you go back 3 months, it takes you to November, right? We have February, then January, December, November, 3 months. Then we add 7 days. So this was February 9th, add your 7 days to November 16th. And then you have, if it's later in the year, remember that you're going to have to change that year. If it's earlier in the year, it may be in that same time. So November 16th, 2015. Just try to commit that to memory, that Nagel's rule, take away 3 months, subtracts 3 months, and add your 7 days. But don't forget about having to change that year depending on when throughout the year it is. Okay. All right. Next slide, please. And then if we could take the poll down, because it's still in the middle of the slide.
Missy, that
Is there
might
a way to
just
do
be
that,
that
Devin,
might
to
just
stop
be on your
sharing the
end.
result?
Missy, it might just be on your
I'm
side.
sorry.
Can you hear me?
Yes.
I think it might just be on your side because I can see
Oh.
that he took it down. So what you can do is just either just
there,
click
okay.
out.
I didn't know that I could clear it. Okay.
There you go. Thank you. Yeah.
All right. Sorry, guys. Okay. So next, a client in the second trimester of pregnancy is seen at the healthcare clinic. The nurse notes that the fetal heart rate is 90 beats per minute. Which nursing action is appropriate? Are we going to notify the healthcare provider, document the findings, inform the mother that everything is normal and fine, or instruct the mother to return to the clinic in 1 week for reevaluation of the fetal heart rate? Can go ahead and put up the poll. There we go. I'll give it a couple more seconds for you guys to get your answers in. All right, has everyone answered that wants to answer? Okay, we're going to end the poll. All right, so absolutely, on this one, you want to notify the healthcare provider. Remember that fetal heart rate, normal fetal heart rate is 110 to 160. So let me get out of this. Okay, so normal fetal heart rate is 110 to 160. So if you come in and you're taking care of a patient whose heart rate that you're seeing on the monitor, the fetal heart rate is 90, you need to notify that healthcare provider because that's problematic. You will eventually, obviously, document the findings, but your first priority needs to be notifying that provider so we can find out what's going on with this baby. Remember too that 110 to 160 is what's normal for a term fetus. If you have a preterm fetus, so a baby prior to 37 weeks, then their heart rate is going to be even higher. So if this patient, it says they're in the second trimester of the pregnancy, so that would be a preterm baby. So if we see a heart rate of 90, this baby is nowhere near what normal would be. So you don't want to inform the mother that everything is normal and fine. And you definitely wouldn't want to send her home and have her come back to the clinic in a week, because this heart rate is so abnormal at this point. So first and foremost, we want to notify the healthcare provider that we have a fetal heart tone of 90. All right. Next question. The nurse is collecting data from a client during her first prenatal visit to the clinic. The nurse takes the client's temperature and notes that the temperature is 99.2 degrees Fahrenheit. Which action is appropriate? Notify the healthcare provider, document the temperature, retake the temperature by rectal route, inform the client that the temperature is elevated and antibiotics may be required. You can go ahead and put up the poll. A few more seconds, guys. All right, in the poll. So we definitely just want to document the temperature here. With maternal health, once pregnancy starts, a normal temperature is 97.8 to 99.6. So a temperature of 99.2 would be completely normal. So we don't need to notify the healthcare provider that the patient's temperature was 99.2. We don't need to retake the temperature, definitely not by a rectal route on an adult. And we wouldn't inform the client that her temperature was elevated and she's not going to need antibiotics. 99.2 would be a completely normal temperature. Therefore, all we would wind up doing is documenting the temperature for this patient. Next slide, please. Which indicates the purpose of Kegel exercises. The exercises will reduce backache. The exercises will prevent ankle edema. The exercises will prevent urinary tract infections. The exercises will help to strengthen the pelvic floor in preparation for delivery. Let's open the poll. All right, another second or two. We're going to end the poll. So definitely the exercises will help to strengthen the pelvic floor muscles. Kegel exercises are exercises that women can do to strengthen their pelvic floor. It doesn't only have to be done during pregnancy. It's very helpful after pregnancy as well. But the purpose of doing them during the pregnancy is that by strengthening the pelvic floor, they can have better strength when they're getting ready to push for their delivery. So the strengthening of those pelvic floor muscles will help prepare them for their eventual delivery. Strengthening the Kegels has nothing at all to do with reduced backache. Strong Kegels will not help with backache at all. Definitely has nothing to do with ankle edema. And it doesn't really help very much with urinary tract infections either. The plain and simple truth is that those muscles in that pelvic floor will just, those being stronger will help them have a better pushing period throughout the end of the stages of their labor. Next slide, please. The nurse is teaching a pregnant client about the warning signs in pregnancy. The nurse determines that the client needs further instructions if the client indicated that which symptom is a warning sign: rapid weight gain, visual disturbances, generalized or facial edema, the presence of irregular painless contractions. Please open the poll. Couple more seconds. All right. So with these, you guys were kind of all over the place. Look at what the question is asking for. The question is saying that the nurse knows that she needs to give better education or more information to this patient when they identify which of the four are warning signs. So the answer for this is the presence of irregular painless contractions. Remember that the presence of an irregular painless contraction is a Braxton-Hicks contraction, which is completely normal. As pregnancy advances, we expect the patient to have these irregular contractions. So if she's thinking that this is a warning sign, then that would tell us that we need to give her more education. If she's telling us that rapid weight gain is a warning sign, she's right, it absolutely is. Rapid weight gain could be associated with preeclampsia. It could be associated with an underlying cardiac condition. So seeing a patient put on weight quickly would be a warning sign. So she wouldn't need more education then because she's answering it correctly. Visual disturbances are definitely a warning sign. Visual disturbances could be related to worsening preeclampsia. Generalized or facial edema could also be a worsening sign related also to preeclampsia or cardiac condition that we could see with the edema getting worse. So the first three answers, the patient would be completely right to identify those as a warning sign. But we would not want her to think that Braxton-Hicks or irregular painless contractions would be a problematic symptom or a warning sign that things were worsening. Okay, do you guys see how that question worked itself out? If you have questions, ask me. I can't see if you put your hand up. I'll just need you to ask the questions if you have a question about something. All right. Okay, next question, please. Or next slide. A non-stress test is prescribed for a pregnant client, and the client asks the nurse about the procedure. What response should the nurse make? The fetus is challenged by uterine contractions to obtain necessary information. The test is an invasive procedure and requires that you sign an informed consent. The test will take about 2 hours and will require close monitoring for 2 hours after the procedure is completed. An ultrasound transducer that records fetal heart activity is secured over the abdomen where the fetal heart is heard most clearly. Please open the poll. We'll leave it open for another couple seconds here. All right, let's go on and end the poll. So a couple things to remember here, guys. Your correct answer is number 4, the ultrasound transducer that records the fetal heart activity. A non-stress test is just exactly what it says. The first answer, a fetus is challenged by uterine contractions. This would be our contraction stress test, where we induce contractions to see if the baby is going to be able to tolerate it, not a non-stress test. The test is an invasive procedure and requires that you sign an informed consent. All this test is, a non-stress test, just uses the external monitoring devices. So it is not an invasive procedure and does not require an informed consent. And the test will take about 2 hours and require close monitoring. A non-stress test at max takes 20 minutes. We want to watch the fetus when it is not under stress for 20 minutes. If we do not obtain a reactive non-stress test in that 20 minutes, we might be able to watch them for a little bit longer, but never more than 40 minutes is the maximum that a non-stress test will take. And remember that we're looking for 2 episodes of an increased heart rate, at least 20 beats above the baseline, and lasting for at least 15 seconds each. So that's our non-stress test. And it does not take any more than 40 minutes maximum. All right. So that's why number 4 is our correct answer, an ultrasound transducer that records fetal heart activity secured over the abdomen where the heart is heard most clearly. All right. Okay. Next slide, please. So our cardiovascular changes. Remember that we talked in class, and this is something that you'll need to keep in mind for your NCLEX, that when the woman becomes pregnant, she must undergo cardiovascular changes to incorporate the amount of extra blood that needs to process through her body and over to the fetus through the placenta. So when the mom becomes pregnant, her blood volume increases by about 30 to 45%. And then her plasma volume between weeks 6 to 8 increases up to about 32 weeks of gestation, and the plasma volume increases 40 to 60%. Then her cardiac output is going to increase. It's going to stay elevated. It will increase by 30 to 50%. All right. Let's do the next slide, please. The nurse provides home care instructions to a client with a history of cardiac disease who has just been told she is pregnant. Which statement by the client indicates the need for further instruction? It's best that I rest on my left side to promote blood return to the heart. I need to avoid excessive prevent increased demands on my heart. I need to try and avoid stressful situations because stress increases the workload on my heart. During the pregnancy, I need to avoid contact with other individuals as much as possible to prevent further infection. Open the poll. Another second or two, guys. All right, let's go on and end the poll. Okay, so remember that this question again is asking what information does the patient give back to us that lets us know that she understands what is going on? And the answer for us is number 4. This lets us know that she needs more education. So her answer is during the pregnancy, I need to avoid contact with other individuals as much as possible to prevent further infection. So that word further is where you should be looking. She doesn't have an infection. So we don't need her to avoid contact with anybody. She doesn't have an infection to begin with. Being in contact with someone else is not going to put her at more risk to increase her infection because she doesn't have an infection. She has a history of cardiac disease. If she told us her first answer, it's best that I rest on my left side to promote blood return to the heart, we know that that's true, right? Left side laying promotes better perfusion to all of our organs. Number 2, I need to avoid excessive weight gain to prevent increased demands on my heart. That's correct. She's telling us that she knows what's going on. The more weight she gains, the more that heart has to, excuse me, has to work. Number 3, I need to try and avoid stressful situations because stress increases the workload on my heart. Again, that's correct. The more stressed she is, the more the heart is working. So we don't want to put excess workload on a heart that already has a cardiac problem. But during the pregnancy, I need to avoid contact with other individuals as much as possible to prevent further infection. That is inaccurate. She doesn't have an infection to begin with, so we don't need to worry about that. Next slide, please. The nurse assists the pregnant client with cardiac disease to identify resources to help her care for her 18-month-old child during the last trimester of pregnancy. The nurse encourages the the pregnant client to use these resources primarily for which purpose? Reduce excessive maternal stress and fatigue, help the mother prepare for labor and delivery, avoid exposure to potential pathogens, prepare the 18-month-old child for maternal separation during hospitalization. Open the poll, please. Couple more seconds, guys. All right, we can go on and end the poll. Okay, definitely the first answer, reduce excessive maternal stress. Remember that we just spoke about the extra stress on someone's heart that already has a cardiac disease. Chasing an 18-month-old around is not easy. We're not asking someone to take their baby away. We're just asking someone to help out during this time. Help the mother prepare for labor and delivery. Really, someone else helping with their 18-month-old is not going to help them prepare for labor and delivery. Avoid exposure to potential pathogens and resulting infections. Having her peanut around isn't going to expose her to potential pathogens. And then prepare the 18-month-old child for maternal separation during hospitalization. Again, we're not asking someone to take their child away. We're just giving them resources to help care for the 18-month-old. So someone else taking care of the 18-month-old isn't really preparing that little one for a maternal separation. We're really just trying to give the mom increased time to be able to rest and relax so that she's not feeling as stressed and fatigued chasing this 18-month-old around all day. Next slide, please. Supine hypotension. We talked about this in class, that once a patient gets to about 20 weeks in their pregnancy, truly, we want to start making sure that they're not lying flat on their back. They want to be wedged a little or on their side. Supine hypotension, what's happening is that the increasing size of that uterus when a woman is laying flat puts pressure on that vena cava and causes a hypotension. So if the hypotension is happening to mom, it's also able to be seen in the fetal heart tones because the blood flow is not going the way that it's supposed to because of that compression from the growing uterus and the size of that baby in there. So we always want to make sure that we're putting a patient in a lateral position, right lateral, left lateral, either one is fine. We don't actually have a sick patient, so we don't have to insist on that left lateral all the time. We're just trying to keep the pressure off of that patient's vena cava. It is sometimes also known as vena cava syndrome, as well as supine hypotension. And we can see lightheaded and dizziness from mom, and then see changes in mom's vital signs and changes in the fetal heart tones. Next slide, please. During the intrapartum period, the nurse is caring for a client in labor who has sickle cell disease. The nurse assures that the client receives appropriate intravenous fluid intake and oxygen consumption, primarily for which purpose? To stimulate the labor process, prevent dehydration and hypoxemia, avoid the necessity of a cesarean delivery, or eliminate the need for analgesic administration. Poll, please. All right, we can go ahead and close the poll. Great job, guys. Absolutely prevent dehydration and hypoxemia. When you're thinking about the sickle cell patient, we know that if they get dehydrated, it can cause more sickling, and that causes increased pain for them and potentials for blood clots and so many other problems. Same thing with pregnancy, except now we have to make sure that the mom is staying hydrated, not only for herself, but also for the fetus. Remember that if sickling is occurring in mom's blood vessels, it's also occurring as it's trying to process through the vessels of the placenta. So it's really important that we always make sure that our sickle cell disease patients are staying well hydrated. Stimulating the labor process, it really has nothing at all to do with that. Avoiding the necessity of a cesarean delivery, IV fluids isn't going to avoid the necessity of a C-section delivery. It's actually imminent. And then eliminate the need for analgesic administration. We also cannot guarantee that IV fluids and oxygen would have anything to do with whether they would need analgesia. So best answer, prevent dehydration and hypoxemia. Very good. Next slide, please. A nurse determines that the client is beginning the second stage of labor when which is documented in the client's record. The contractions are regular, the membranes, the cervix is completely dilated, the client begins to expel vaginal fluid. Pull, please. All right, let's go ahead and close the poll. Okay, guys. So the answer here is when the cervix is completely dilated. Go back before you take NCLEX if you struggled with this one and review the stages of labor. Remember that this is completely different than the phases of labor. With our stages, there are 4 stages. The first stage is onset of labor to complete dilation. The second stage starts with complete dilation to the delivery of the baby. The third stage starts with delivery of the baby to the delivery of the placenta. And the fourth stage, which is recovery, starts from the delivery of the placenta through the end of the 2 hours of the recovery process. So with this one, second stage of labor is starting when the cervix is completely dilated. Okay, so number 3 was your correct answer. The nurse is monitoring a client in labor, and the client's membranes rupture spontaneously. Which is the priority nursing action? Determine the fetal heart rate, provide peri-pads to the client, take the client's blood pressure, note the amount, color, and odor of the amniotic fluid. Pull, please. Another second or two. All right. Definitely priority. That was your key word. It's even in bright red letters there. Priority is determining the fetal heart rate. Absolutely the first thing that you want to do after the membranes rupture, whether it be a spontaneous rupture or whether it be an artificial rupture. Remember, spontaneous is when the body just breaks the water. Artificial is when the doctor breaks the water. But always our first nursing action is going to be to determine the fetal heart rate. After that, we absolutely will give the patient more peri-pads. We will give make a note about the amount, color, and odor. But our first intervention, our first priority has to always be those fetal heart tones. Next slide, please. The nurse assists in the vaginal delivery of a newborn. Following the delivery, the nurse observes the umbilical cord lengthen and a spurt of dark red blood from the vagina. The nurse documents these observations as signs of which condition? Hematoma, uterine atony, placenta previa, placental separation. Poll, please. Another second or two. All right. Okay, definitely placental separation. So if you look at these three different things, a hematoma, we know that a hematoma is a bluish, painful spot on the perineum, and we see it usually after the delivery. It's a broken blood vessel that's bleeding into the tissue. So not really something that we would normally see while the placenta is still inside. Uterine atony, we wouldn't necessarily see the umbilical cord lengthen because of uterine atony. We might see increased bleeding, but that would be the uterus not contracting. And then placenta previa, we wouldn't have seen a vaginal delivery if we had a placenta previa, because the placenta previa would have been covering the cervix, so we wouldn't have been able to deliver vaginally. Placental separation. Remember that when the placenta starts to peel away from the uterine lining, you're going to see that dark red bleeding because it's forming its own type of wound against the uterine wall. But you're going to see that umbilical cord lengthening because the placenta is starting to come down, and that umbilical cord is still attached to that placenta. So as the placenta starts to make its way down, that umbilical cord is going to lengthen, and you're going to see that spurt of the dark red blood when that placenta peels away finally in this recovery stage, because this is ending the third stage and going into our fourth stage of labor. Next slide, please. This is showing you that whole placental separation. So if you notice, as that cord is there, they've they've cut the cord already and taken the baby away from it, but the cord is still hanging while they're waiting for that placenta to detach from the uterus. As that placenta starts to detach, you'll see that that cord gets longer as that placenta is making its way further down in the uterus to be expelled vaginally. And that's what each of these slides is showing you. We see as it's starting to peel away in B and then making its descent in C down through the uterus, and then in D being expelled through the vagina. So you can see how that cord would lengthen each time. All right, and that's the placental separation process. Next slide, please. This is your vaginal hematoma. It's actually a perineal hematoma here because you're seeing it on the perineum. A vaginal hematoma, you would have to separate the labia and you would see the hematoma in there, but it's this deep bluish purple formation of a bulge of tissue. And it's because there's a broken vessel that is bleeding into that tissue. Remember that if someone is complaining of pain and they've already had pain medication, but it hasn't taken away any of the pain, and they're still feeling severe pressure in their perineum or in the vaginal vault, we have to suspect a hematoma and we need to go looking for it. Next slide, please. So uterine atony is when the uterus is not contracting. And so it is also that boggy uterus that we talked about in class, when it just feels like a water balloon, like a very squishy water balloon. When you have a contracted uterus and you palpate that uterus, it's going to feel firm like a ball inside the patient's abdomen, and the bleeding should be minimum. When you have this uterine atony, it's going to be a very boggy, squishy uterus because there's no firmness to it. You're not going to feel that nice firm ball. It's going to be that squishy water balloon feel to it. And as you press, you will see increased bleeding coming out vaginally because all of the blood is pooling inside the uterus with this uterine atony. And as you're pushing, you're expelling that blood. Uterine atony definitely leads us to need to start doing abdominal massage for the uterus so that we can get that uterus to firm up through our massaging, and then also potentially through the use of medications as well to help that uterus start to contract. But that's the difference between your contracted uterus and uterine atony, is very firm uterus with very little bleeding compared to a very squishy water balloon-like uterus with increased bleeding. Next slide, please. When we massage the fundus, it's extremely important to make sure that you are supporting the lower segment of the uterus with your non-dominant hand. So you're going right above the pelvic bone to support the bottom of that uterus. Then you're taking your dominant hand, putting it on top of where you feel the top of the uterus, also known as the fundus. And then you're massaging down, pushing one hand towards the other to compress the fundus towards that lower segment. Now, we do this in just a regular fundal assessment. And as long as the uterus is firm, we're really just pressing down to feel that firmness. But if we find that uterine atony or that boggy uterus, then we're continuing to do a more aggressive fundal massage to get that uterus to firm up. But always make sure that you have that non-dominant hand compressing the lower segment of the uterus. If you start a fundal massage without having that that support for the lower segment,
Bye.
then you are going to wind up having that uterus prolapse vaginally. So just make sure you've always got that lower segment uterine support. Next slide, please. The nurse in the postpartum unit is caring for a client who has just delivered a newborn following a pregnancy with placenta previa. The nurse prepares to monitor the client for which risk associated with placenta previa: infection, hemorrhage, chronic hypertension, disseminated intravascular coagulation, or DIC. Poll, please. All right, another second or two. All right, I'm going to end the poll. Okay, hemorrhage is definitely your associated risk with a placenta previa. Infection is no greater with a patient that has a placenta previa as a patient that had no complications. And then DIC is more seen with placental abruptions than a placenta previa. Because the placenta previa had attached itself to either all of or part of the cervix, it increases the risk of hemorrhage. So if we have a patient that had a placenta previa, we always want to be watching them close for risk for hemorrhage. Next slide, please. So this is your placenta previa. Remember that placenta previa is any type of involvement between the placenta and the cervix. That's what constitutes a placenta previa. So we can have a total placenta previa, as you see in this bottom slide, where the entire cervix is completely covered by the placenta. Has to deliver with a C-section. There's no way that we can do a vaginal delivery because the placenta is blocking the vaginal opening. You can have a partial placenta previa, which is the slide or the picture off to the right, where a section of the placenta is in contact with a section of the cervix. A C-section for this baby as well, because the cervix and the placenta, if mom goes into labor, the contractions will cause both of them to be irritated and the bleeding will get excessive and mom and baby could bleed out from that. So we would do a C-section as well. If you have a marginal placenta previa, that's where the margin, the outer edge of the placenta comes in contact with the outer edge or the border of the cervix. And this can sometimes correct itself as the uterus grows for this pregnancy. But again, at the time of delivery, if there is any contact between the placenta and the cervix, we will not let that patient deliver vaginally. Next slide, please. Difference between placenta previa and placental abruption, abruptio placentae, is that the placenta is in the correct placement here. What happens with an abruptio placenta is that the placenta peels away from the uterine lining. So we can also have a complete abruption, a marginal abruption, or a partial abruption. If we have a complete abruption where the placenta completely peels away from the uterine lining, This is an automatic life and death crisis. Mom and baby are both bleeding out. Baby is not getting any oxygenation from mom, and we have to perform an emergency C-section as quickly as we can to save this baby. If we have a partial abruption, sometimes a partial or a marginal abruption will heal itself back over. That placenta will never, at that spot that it's abrupted, it will never reattach to the uterine lining. But because it's only a partial or a marginal, there's still enough of the placenta attached that as long as the baby is not showing signs of distress and the bleeding does not continue, we can continue to allow the pregnancy to progress. But if we have signs of distress from a baby that has any type of abruption, we immediately need to go with delivery. Remember, the difference between abruption and previa is that placenta previa has painless bleeding. Abruptio placenta has painful bleeding. Next slide, please. The nurse is assisting in caring for a client with abruptio placentae and is monitoring the client for disseminated intravascular coagulation, DIC. Which finding is least likely associated with DIC? Prolonged clotting times, decreased platelet count, discomfort in the sacral area, petechiae, oozing from injection sites, and hematuria. Poll, please. Another second or two. All right, let's end the poll. And here we go. Definitely discomfort in the sacral area. Remember, guys, least likely associated with DIC. DIC is bleeding from every orifice. We would see prolonged clotting times because this patient isn't clotting, right? That's why they're bleeding out. Their clotting factors are basically gone. Decreased platelet count, definitely would see that. When the platelet count decreases, our patients have trouble clotting. Petechiae, oozing from injection sites, and hematuria. That is the definition of DIC, isn't it? We see oozing from everywhere. But we don't see discomfort in the sacral area. It has nothing to do with DIC. So the least likely finding would be discomfort in the sacral area. So number 3 would be your answer for that. Next slide, please. The nurse is preparing to assist in performing a fundal assessment on a postpartum client. The nurse understands that which is the initial nursing action when performing this assessment. Ask the client to turn on her side. Ask the client to urinate and empty her bladder. Massage the fundus gently prior to determining the level of the fundus. Ask the with the knees and legs flat and straight. Poll, please. Just another second or two. All right, ending the poll. Okay. You definitely want to ask the client to urinate and empty her bladder. Remember that we have talked about in the past that if the patient has a full bladder, it can push the uterus up and off to the side. When we push that uterus up and off to the side, then it predisposes that patient for potential hemorrhage. So when we're going in to assess our patient and find out truly where the fundus is and if it's firm, we want their bladder to be empty so that it's not skewing where the uterus should normally be. The uterus should be midline. And if the client's bladder is full, it will not be midline. We don't necessarily need the client to be laying completely flat on her back with her knees and legs flat and straight. And we don't massage the fundus prior to determining the level of the fundus. The answer for this is definitely to ask the client to urinate and empty her bladder. Next slide, please. Palpating the fundus of the uterus. We kind of went over this in a couple other slides, but always make sure that you're giving that lower segment support as you're pushing to find the top of that uterus, which is the fundus. You're looking for the very top. You're hopefully finding that nice firm ball. But you can see in this picture that the bladder is there. And if the bladder were to fill, you wouldn't be getting a great assessment of that fundus. Next slide, please. The involution process. So it's important that although we look for the uterus to go down a certain amount each day, the important fact to keep in mind is that as long as it is going down and not up in the opposite direction, then we have involution. And involution is necessary after delivery. So generally, when a patient delivers, we look to find their uterus somewhere around the umbilicus, usually right below the umbilicus. And then it should go down 1 finger's breadth for each day. So if a patient is 2 days out from having had her baby, we should be palpating the uterus about 2 finger breadths below the umbilicus. Keep in mind, though, that whether this patient is a multip, so someone who has had multiple babies, or a primip, their first-time baby, can make a difference in how quickly the involution process happens. After having more than 1 baby, the uterus takes a little bit longer to shrink down to its original size, which is about the size of the fist of the mom. So if we have in one room a woman that just had her first baby, and we go in there day 1 and she's down 2 or 3 finger breadths, that's great. The uterus enlarged to carry the baby and then immediately started into its involution process. If we go into our next patient's room and she's had her 3rd baby 1 day ago, and we're only 1 finger breadth below the umbilicus, totally fine as well, because we know that it may take her uterus, since it's been enlarged multiple times, take more time to be able to shrink down to its original state. All right. By day 14, for both moms, whether it be primip or multip, that uterus should be getting down into the pelvic cavity, and we shouldn't really be able to palpate it just by applying pressure on their abdomen by that time. Next slide, please. The nurse is inspecting the lochia discharge on a 1-day postpartum woman. On inspection, the nurse notes that the lochia is red in color and has a foul-smelling odor. The nurse determines that this finding indicates which situation is normal, the presence of an infection, the need for increased oral fluids, the need for increased ambulation. Pull, please. All right, I'll leave it open for like another second or two. Okay, ending the poll. So sorry, guys, I just lost my whole internet connection. Everything went down. I'm back. Sorry. So back to this question about the lochia. Anytime we have lochia that has a foul smelling odor, we have to immediately assume that there is an infection present. So number 2 would be our option here, presence of infection. It's never normal to have odor, and it's not like urine that you need to increase their oral fluids because they have this odor, and we definitely wouldn't have just a need to get them up moving more. It's that there's possible presence of an infection. Next slide, please. Again, I'm so sorry. So this is how we measure the amount of lochia when we're looking at a patient's perineal pad. If they've got just a little bit, just a smear, that's just scant bleeding that we're looking at. If they have light bleeding, like a 1 to a saturation of the pad, that is light bleeding. If the majority of the pad is covered, 4 to 6 inches of the pad, then we're looking at like a moderate bleeding. And if it's saturated, the entire pad is covered, then that's a large amount of bleeding. And if they are saturating more than a pad in an hour, we really need to be very cautious of that and make sure that we're making sure that fundus is nice and firm and that they don't have like a laceration that's bleeding that we're not catching. So just make sure you're looking for scant, light, moderate, or large bleeding and intervening when we need to. Next slide, please. We can go to the next slide, Devin.
I have the question, the postpartum client. Do you see that on your screen?
Okay, there we go. Yep, it just came up.
Okay, seems like we're still having some internet stuff. Just let me know.
It may be my internet, honestly. The postpartum client asks the nurse about the occurrence of after pains. The nurse informs the mother that after pains will be especially noticeable in which situation? When ambulating, during breastfeeding, while taking sitz baths, once the client arrives home and activities are increased. Poll, please. All right. One more second, and then we'll end the poll. Okay, go on and end the poll, Devin. Thank you. So it's definitely during breastfeeding, guys. Ambulation really has nothing to do with after pains, and the after pains actually should be getting a little bit better once the patient arrives home. But remember that during breastfeeding initiates the release of Pitocin, which means that it causes contractions while they're breastfeeding. So we'll definitely see the after pains more then. And also remember that when a patient has had multiple children, after pains are worse for them, especially with breastfeeding. First-time moms don't notice the after pains as much as moms who have had multiple babies. All right. Next slide. The nurse is monitoring a new mother in the 4th stage of labor for signs of hemorrhage, which is a sign of blood loss. A temperature increase to 100.4 Fahrenheit, an increased pulse rate of 88 to 120 beats per minute, a blood pressure change from 130 over 88 to 124 over 80, an increased respiratory rate from 18 to 22 breaths per minute. Poll, please. All right, another couple seconds. All right, Devin, we can end the poll. Thank you. Yes, an increased pulse rate from 88 to 120. I can see why you would have wanted to pick the blood pressure change from 130 over 88 to 124 over 80, because when we see hypovolemic problems, we generally see an increase in the pulse rate and a decrease in the blood pressure. But this blood pressure of 124 over 80 is still a normal blood pressure. So what we're looking at is that's a huge jump from 88 to 120, and that's that tachycardia that's happening because of the blood loss. So number 2 is your correct answer for that. Next slide, please. The nurse is monitoring a postpartum client in the 4th stage of labor, which finding, if noted by the nurse, would indicate a complication related to a laceration of the birth canal, the presence of red lochia, palpation of the uterus as a firm contracted ball, the saturation of more than 1 peripad per hour, palpation of the fundus at the level of the umbilicus. Open the poll, please. All right, 1 or 2 more seconds, guys. Okay, go on and close the poll. Saturation of more than 1 peripad per hour. So just the presence of red lochia, we're going to have that anyway. That patient's basically just delivered her baby, so you're going to have the lochia. Palpation of the uterus as a firm contracted ball. That's actually what we want, isn't it? We want that firm uterus. The saturation of more than 1 peripad per hour tells us that there is a problem with that bleeding. So we need to make sure that we're checking into that. Next question, or next slide. The postpartum nurse has provided instructions to a new mother on how to bathe her newborn. Which observation indicates that the mother is performing the procedure correctly? The mother begins to wash the newborn by starting with the eyes and face. The mother cleans the newborn's ears and then moves to the eyes and the face. The mother washes the arms, chest, and back, followed by the neck, arms, and face. The mother washes the newborn's entire body and then washes the eyes, face, and scalp. Poll, please. Do another couple seconds. End the poll, please. Mother begins to wash the newborn by starting with the eyes and the face. Remember that you wash a baby essentially the same way that you would do an adult. And we always start with the face first. We don't want to wash their whole body and then bring that dirty wash rag up and start doing their eyes and their face. So always begins with washing the eyes and then the face. All right. Next slide. Methods of heat loss. So we went over heat loss pretty extensively in class. We have evaporation that occurs when you have the baby in something wet. So either evaporation that from their bath, or they're laying on a wet towel or a wet blanket, or even if their diaper or their clothes stay wet. We have conduction, which is when the baby comes in contact with a cold object. Like if you don't put down a chucks or a blanket to lay the baby on the cold scale. Convection occurs from drafts and windows. And then heat loss through radiation is when a cold surface near the baby pulls that baby's heat away from them. Next slide. The nurse in the newborn nursery is monitoring a preterm newborn for respiratory distress syndrome, RDS. Which findings would alert the nurse to the possibility of this syndrome? Tachypnea and retractions, acrocyanosis and grunting, hypotension and bradycardia, the presence of a barrel chest with acrocyanosis. Poll, please. All right, a couple more seconds, guys. End the poll, please. Tachypnea and retractions. The acrocyanosis and grunting is absolutely correct. But remember that acrocyanosis is a normal sign after delivery. It's not a sign of respiratory distress. Oral cyanosis would be a sign of respiratory distress. But acrocyanosis is those little blue fingers and toes after being born, and that's a perfusion sign, not a respiratory sign. Tachypnea and retractions, absolutely signs of respiratory distress, some of the main signs of respiratory distress. So don't confuse your acrocyanosis with oral cyanosis. Next slide, please. What is a normal respiratory rate for a newborn? 20 breaths per minute, 40 breaths per minute, 70 breaths per minute, 80 breaths per minute. Poll, please. Another second or two. All right, let's close the poll. 40 breaths per minute. Normal respirations for a newborn are 30 to 60 irregular breaths per minute. So 20 would be too low, 70 too high, 80 definitely too high. Those would be our tachypnea. So 40 breaths falls into that 30 to 60 irregular breaths per minute. Next slide, please. The postpartum nurse provides instructions to the mother of a newborn who has hyperbilirubinemia that is being breastfed. Which instruction should the nurse provide to the mother? Increase the frequency of the breastfeeding, stop the breastfeeding and switch to bottle feeding permanently, provide bottled water feedings between the breastfeeding sessions, switch to bottle feeding the baby during the period of high bilirubin levels, and feed less frequently. Poll, please. All right, another second or so. Okay, we can go on and close the poll. Increased frequency of breastfeeding. If a mom is breastfeeding, we never want to discourage her from breastfeeding, and hyperbilirubinemia should not be a reason to do that. But remember that we want to get more food into the baby so that they're stooling the increased bilirubin out. And so increasing the breastfeeding is the best way to do it. We don't need to switch to bottle feeding. Breastfeeding will do a great job with it. And we never, ever, ever give baby bottled water feedings. It is useless, no calories. It does nothing for them. It just fills them up. So it just means that they're not taking in nutrition when they should. And we would never want to decrease the feeding schedule. We want to increase it to get that bilirubin out. Next slide, please. Methergine is prescribed for a client to treat postpartum hemorrhage. The nurse collects data regarding which priority item before administration of the medication: uterine tone, blood pressure, amount of lochia, or deep tendon reflexes. Poll, please. All right, one more second. Let's go on and close the poll. Blood pressure. Remember, guys, we talked about this in class, that if a patient has had high blood pressure, we cannot give them Methergine. If they have had high blood pressure, they have to get a medication called Hemabate. Hemabate causes the extreme diarrhea. So Methergine is truly our drug of choice, but if a patient has had high blood pressure, we will send them into an extremely high blood pressure by giving them Methergine. So Methergine is contraindicated with patients with high blood pressure. Next slide, please. The nurse is caring for a client who's receiving Pitocin by IV drip for the induction of labor, which finding indicates the need to contact the healthcare provider. Fatigue, drowsiness, uterine hyperstimulation, fetal heart rate of 140 beats per minute. Poll, please. Just another second or so. All right, let's close the poll. Uterine hyperstimulation. Pitocin really has nothing to do with drowsiness, so that wouldn't be anything we would need to contact the doctor for. And a fetal heart tones of 140 beats per minute is completely normal, with 110 to 160 being their normal heart rate. But hyperstimulation, if the contractions are coming too frequently, which is what uterine hyperstimulation is, then that baby is not getting a chance to recover in between the contractions. And so that's why we would need to contact the physician about uterine hyperstimulation. Next slide, please. A pregnant client is receiving magnesium sulfate to treat preeclampsia. The nurse identifies that the client has developed an unwanted outcome if which finding is noted: proteinuria of 3+, presence of deep tendon reflexes, serum magnesium level of 6, respirations of 10 breaths per minute. Poll, please. Just another second or two, guys. Let's close the poll. Respirations of 10 breaths per minute. Remember that mag sulfate toxicity causes respiratory depression. Respiratory depression has to be our #1 thing that we're focusing on. Proteinuria of 3+ has to do with the preeclampsia, not the magnesium sulfate. And presence of deep tendon reflexes, we want them to have deep tendon reflexes. Absence of reflexes would be what would indicate that there was a problem. And a MAG level of 6 is normal, so that would be fine. Respiratory depression is what we have to watch for with MAG sulfate. Next slide, please. So this next slide doesn't actually have a way for you guys to answer. So I'm just going to work through it with you since I've kind of run over on my time. A nurse is caring for a pregnant client with severe preeclampsia who's receiving IV mag sulfate. Which nursing interventions apply in the care of this client? Select all that apply. So patients getting mag sulfate for preeclampsia. We want to monitor deep tendon reflexes hourly. Yes, because worsening deep tendon reflexes would indicate that preeclampsia was getting worse. Absence of deep tendon reflexes would tell us that we have a toxicity with the mag sulfate. So we monitor these hourly. Monitor maternal vital signs every 4 hours. Absolutely not. We are monitoring vital signs hourly for these patients that are on mag sulfate. Respiratory depression is #1 thing we need to watch for, right? We just discussed that in the last slide. If we're only looking for this every 4 hours, a patient could be completely toxic within 4 hours before we could even do anything about it. Monitor renal function and cardiac function closely. The doctors do watch the lab values closely because mag sulfate can cause toxicity with renal output. Monitor the notify the healthcare provider if respirations are 18 per minute. No, 18 per minute is fine. 10 per minute, we'd have issues with. Keep calcium gluconate on hand in case of magnesium sulfate overdose. Absolutely. If we see mag toxicity happening, we need to have calcium gluconate on hand to reverse the effects of the mag sulfate. Notify the healthcare provider if urinary output is less than 30 milliliters per hour. Yes, normal output is minimum of 30 milliliters per hour. If we drop below that, we have mag toxicity affecting the kidneys, and we need to let the healthcare provider know. I think that's the last slide, isn't it, Devin?
Yep, that's it.
All right. Good luck, everybody. I really hope that you do amazing on your NCLEX. I know that these reviews in each of the sections will help, and I have my fingers crossed for you. See you all at graduation. Angie, thanks again for inviting me.
Thank you, Missy. Thank you so much. Really appreciate your time.
Not a problem. My pleasure. Good luck, guys.
See you, Missy. Devin, I'm not sure. Do you want to put do we have to move to another link for mental health?
Yes, I'm gonna put it in the chat right now.
Excellent. All right, guys, we will see you over at the next link. So why don't you take until 2:20 so you have the full 15 minutes. See you guys there. Thank you.